the focus today is on transplant and learning a little bit more about the role that transplant can play and how getting ready for transplant, for instance, and other evaluations, and thinking about living a donation, and then about the transplant surgery side of it is going to be the focus of the presentation today. Naim Issa is getting ready for kidney transplant. Is going to be the first presentation. He's a relatively new nephrologist here, although he did training here previously, and he's going to talk about the getting ready for transplantation from the side of the nephrologist.
Sure. Okay. Thank you so much for the invitation. Can you hear me? Okay.
Yes. Yes.
Okay. Thank you for the invitation. Actually, I'm gonna start the webinar today discussing how we do our evaluation for kidney transplantation, and I'll try my best. Actually, it's quite a standardized evaluation that we do. It's not very particular to the Mayo Clinic. It's actually standard across the board in many institutions and many transplant centers. I have nothing to disclose. Always when I see patients in my clinic, we discuss the option for kidney transplantation and other options, different modalities for renal replacement therapies. I actually start my evaluation by discussing with them why kidney transplantation to date is the best form of therapy for patients who are afflicted with kidney disease. Typically, I go over this, and then we start the evaluation process. So that's an outline of what I'm going to discuss today. We'll talk about why kidney transplantation, why it's the best form of therapy available to us now, why it's superior to other modalities. And in particular, I'm going to talk about why living kidney donor transplantation, why it's the best option available today. Yeah, it is important to note that kidney transplantation is not a cure for kidney disease, for end-stage kidney disease. It's a form of therapy. You still need to go see the doctor. You still need to have labs done and frequent visits. And then we'll talk about the evaluation process in order to getting you listed for kidney transplantation. So why kidney transplantation? Simply because people live longer after kidney transplant than they do on dialysis. I'll go over the evidence in the next few slides. And of course, kidney transplantation provides more freedom than dialysis. It's really important to note that recipients of kidney transplant have a longer life expectancy than patients who remain on dialysis. As highlighted on those slides, based on some estimates from 2012, recipients of kidney transplant had actually about 2.5 times more remaining years of life than patients who remain on dialysis. I like to take an example. For example, if you're 40-year-old and your kidneys failed and you're faced with options for modalities of renal replacement therapy, if you get kidney transplant, your lifespan is actually almost a normal lifespan, can be up to 30 years. If you start dialysis, unfortunately, this does not confer you long life expectancy. It can be around 8 to 10 years. So this is why kidney transplantation is the preferred modality for renal replacement therapy, simply because put you back on the normal life expectancy. And that's seen across all age groups, even in older people. Kidney transplant still is the best modality and increase your lifespan. And it has been shown it's also in females, males, across the board, all age group, all ethnic backgrounds, including Caucasians, African Americans, and Hispanics. Kidney transplantation is the winner. Unfortunately, kidney dialysis or dialysis is not a good option. It's in a way it's good that you keep you healthy in terms of prolong your lifespan for a short period of time, but it's actually unfortunately in this country especially people who undergo dialysis don't live long, and this is highlighted in this slide. 60 out of 100 patients who start dialysis actually die at 5 years after starting dialysis. So actually, it's worse than some common cancers like melanoma, prostate cancer, breast cancers in females, and kidney cancer, even colon and rectal cancer. So it's really not the best option to remain on dialysis as it increases mortality.
You're having trouble hearing.
Okay.
Can I take this away and
Great.
that? Because I wonder if because it's
Sure.
coming out there.
I'll be closer.
Thank you.
Other benefits of kidney transplant are important, especially the quality of life benefits that it confers. People can maintain their employment. They're free of dialysis constraints. They don't have to devote 3 days of their week to dialysis. And you know, the dialysis days start going to the dialysis unit an hour before to get hooked to the dialysis machine, spend 3 to 4 hours, then wait after doing dialysis if there is any problem like prolonged bleed from fistula and such. So a whole day is wasted on dialysis. Transplant actually it's better in that regard because you mainly take immunosuppression medication. You don't have to commit yourself to 3 times a week dialysis. Relatively unrestricted diet, especially in PKD patients, because typically PKD patients don't have other comorbidities such as diabetes and other things. So it confers actually relatively and give you a relatively unrestricted diet. Freedom to travel, that's important. And more importantly, in childbearing age, women at childbearing age can be able to become pregnant and bear children after transplantation, something that they can't do while on dialysis or while they have advanced chronic kidney disease. Engaging in sports and physical training is also an important aspect of an added quality of life benefit for kidney transplantation. Now, kidney transplantation is the winner. Why we actually advocate for a living donor kidney transplantation? Because living donor transplant actually is better in terms of the survival of the kidney transplant. Also gives you higher life expectancy. If you compare on this slide, in yellow here, if you get kidney transplant from a living donor versus in blue, a dead donor, you can appreciate that a living donor transplant confers better life expectancy and better survival. And it's actually across all age groups. And if you compare it to dialysis, also it's better. Even in older people, actually, still a living donor transplant is a preferred option when it comes to modality of treatment for end-stage kidney disease. Unfortunately, the waiting times are increasing across the country. Here in Minnesota, average waiting time for a deceased donor is about 5 years. Depending on the blood group, it can go up to 6 years. Some other areas in the country, they have higher waiting time, can be actually up to 9 and 10 years for a deceased donor kidney transplant. And this is a snapshot from few years back, and shows you that only 1 out of 5 newly waitlisted patients received the deceased donor kidney transplant within 3 years. And there are more and more data, actually more updated data, but this is from 2010. 63% of patients placed on the waiting list in 2010 did not receive kidney transplant within 3 years. So the best option is if you have an available living donor, that would be the best preferred option. What are the added advantages for a living donor transplant? You have the preemptive transplant option. Before needing dialysis, as I showed you the evidence, when dialysis starts, we tell patients it's when the clock starts to tick. So the preemptive option is very important. Actually, there are a lot of evidence showing that when we do a preemptive transplant before needing dialysis, we have the best patient survival and the best kidney transplant survival. And we always advocate when we see patients at the time of evaluation, we advocate for them to get the preemptive transplant option before starting dialysis. Of course, there's no wait for a deceased donor kidney transplant. It can be really prolonged. We can, if you have options for many donors, we can actually select the best donor that matches you in terms of tissue typing and HLA matching. Also, donor age is very important because the youngest the donor, the best in terms of all outcomes, whether the kidney survival or patient survival. So if you have several donors, we can actually pick the best donor for you. And the organ actually works very quickly. It's only about 30 minutes apart from getting the kidney, procuring the kidney and transplanting it. There's no need to put the kidney on ice, and that avoids the storage injury related to putting the kidney on ice. The kidney function right away in 99% of the cases. In deceased donor, we get kidneys from everywhere. Sometimes the ischemia time, the ice storage time can be long, can be up to 24 hours. So the kidney may not kick in right away. Patient may still need dialysis for short periods of time, for a few weeks until the kidney kicks in. So a living donor option would actually avoid that. And you can time the transplant surgery for convenience. You can direct the transplant center and say, my donor time has time constraints and would like to do the transplant, at any time. And typically, most of the transplant centers are very accommodating in terms of timing the surgery for the convenience of both recipient and donor. And the anti-rejection medication we use may be less aggressive in living donation transplantation, simply because the kidney function right away. We don't have to keep hammering the immune system with heavy drugs. So it has a lot of repercussion down the road because it avoids having infections and cancers related to the use of heavy immunosuppressive medication. And overall better outcomes than deceased donor transplant, as I showed you before. Now, having said that kidney transplantation is the winner, living donor transplantation is the best option when it comes to modality of treatment for chronic kidney disease or end-stage kidney disease, how we do the evaluation process. And I'll go over the next few slides about how we do things. It's actually, as I said, it's standardized across the board, across many centers. Actually, we all do the same. There are certain things that some centers do more than others, depending on the location in the country, but typically it's a standardized testing. So first of all, we ask the patient, to be their own advocate, meaning talk to your nephrologist, talk to your providers about early referral. Typically, we start thinking about referral to the transplant center when the kidney function or GFR reaches 30 and below. However, you can't get listed on the national waiting list until the kidney function reaches about 20% or below. So the magical number for that GFR is 20 to start accruing waiting time on the waiting list. And of course, you should ask your provider for a referral to the transplant center. You know, a lot of times it's disheartening when we see patients getting referred really late in the game when they are on dialysis for many years, or when they have advanced chronic kidney disease on the verge of getting dialysis, and they lose all those years of waiting time that they could have gained if they were referred early. And we also counsel people and patients when they come to let your family and loved ones know about your need. There is no shame from telling people you have chronic kidney disease. The waiting time is long for a kidney transplant from a deceased donor. And just throw this to your family that the best option is a living donor kidney transplant. And you'll be surprised how many times out of the blue someone stepped in and say, I want to donate the kidney, which can be really great. You get referred, we do all the required testing. And of course, if you don't have the living donor option, you get listed for a deceased donor. Now, there are some major disqualifications for kidney transplantation, and those are the main ones. And certain centers have different criteria, but those are the most common ones. If the patient has an active or chronic infection that cannot be cured, that's a contraindication. The active infection can be cured. We wait till this infection resolves, and then we provide the patient with a transplant. An active malignancy, current malignancy or cancer. Typically, patients are not really disqualified if they have a cancer. We have criteria that we follow depending on the type of cancer. If it's cured, we wait for most cancers about 2 years. And some of them, we actually wait up to 5 years to make sure the patient is really cured from the cancer before considering transplantation, simply because we use heavy immunosuppression, heavy anti-rejection medication. So we don't want any dormant cancer or latent cancer to wake up. It's an important point for disqualification that the patient has history of non-compliance with medical therapies, not able to take the anti-rejection medication, people who skip their dialysis treatments. Actually, we don't list them for transplant until they prove to us that they are compliant with medical therapy. An active mental illness without a suitable caretaker, but we transplant people with certain mental illnesses if it controls on medications. Decompensated liver disease such as cirrhosis. We transplant patients with cirrhosis. For PKD patients, a lot of PKD patients would have liver cysts. Typically, it's not a major problem for transplantation unless the cysts are symptomatic or causing problems. So patient can still have access to transplantation if they have polycystic liver disease. Severe irreversible heart dysfunction. Patients who have heart failure, advanced heart failure, or coronary artery blockages that we cannot treat, that may pose a problem, may actually cause them to have issues during surgery and after surgery. Another point that disqualifies patients from access to transplantation, a poor functional status, patient who cannot able to rehabilitate after the surgery or able to walk and do their daily living. Active substance use, also another point. Depending on the substance use, we sometimes give patients time to abstain from substance use until they prove to us that they have complete abstinence. And that's a debatable point, extreme overweight or obesity. Depending on the center, certain centers have criteria for body mass index in range to 35 or 40. So depending on the center, this is actually can be a relative contraindication. But extreme overweight, people who are really overweight, BMI more than 40, we actually discuss with them weight loss, and a lot of times we actually help them getting access to weight loss surgery prior to transplantation. And we do that at Mayo Clinic, and other centers do that. So what do you expect when you come for your appointments? Before your appointment, actually, you'll be assigned the transplant coordinator, who will gather information, your medical information from different institutions and your doctors. You know, we review those prior to your appointment, and we invite you if we think, you know, you're a good candidate for transplantation or can have access to transplant. The visit typically, depending on the center, will last between 2 to 3 days. Can be more prolonged depending on the needs of the patient. You'll meet with different team members, nephrologists, the transplant surgeon, social workers, dietitian, financial advisor, and pharmacist. We actually do a thorough job in terms of yeah, 5 minutes, okay, when we do the evaluations. And depending on the medical background, we may actually ask for more consults from a heart doctor, a hematologist, endocrinologist, depending on the case. During the visit, what we do is we do a thorough medical and surgical and psychosocial history. Then we do a detailed physical exam. You'll have an extensive blood work, sometimes up to 12 tubes of blood. We do basic stuff such as chest X-ray and electrocardiogram. And there are special considerations for PKD patients who never been screened for brain aneurysm, especially if they have family history of brain aneurysm, of bleeding, cerebral bleeding. We actually subject them to more testing, such as an MRI. And there are other tests that depend on the patient's medical background that we do, such as stress test, CT scan, or more blood work. And of course, we get records for the age-appropriate screening tests. You cannot get listed if you're a certain age, for example, older than 50, you never had a colonoscopy. That's something that you need to do. After your visit, the case will be discussed at the Transplant Selection Committee meeting, where there are different members of the team that you actually met during your evaluation, and some other surgeons and transplant specialists. And after, we do a fair job in actually advocating for you to get listed for transplantation. And the committee decisions can be one of three. Can be listed, active, temporarily inactive. You still have some testing that needs to be done. We can defer your case if there is any ongoing issue or active infection until this is resolved, and then we reconsider the case depending on each particular case, or you can be denied. Now, if you get denied at certain center, that does not mean you are disqualified from getting access to transplant, because we give you the options of seeking another second opinion at a different transplant center. And actually, you can have the option of double listing and triple listing in different transplant centers. So as I said, you can have a living donor or deceased donor. The option for living donor is the best, because every lifespan of a living donor kidney actually is, we say it's about 20 years. 50% of more of living donor transplant lasts actually even more than 15 years. When you get listed for a deceased donor, when you don't have a living donor, there are things that you need to know, that if you're sensitized, having antibodies to HLA antigens, before the transplant, your waiting time can be long, can be more prolonged than the typical 4 or 5 years. Unfortunately, blood type group O and B can wait longer than others. In certain geographic areas of the country, the waiting time for a deceased donor can be really prolonged. Actually, in certain areas, such as, for example, Chicago, can be up to 9 years and 10 years of waiting time for a deceased donor. We list you on UNOS, the United Network for Organ Sharing. It's a federal agency that oversees transplant and deceased donor allocation organs. We list you when you hit that GFR or kidney function of 20. You have to have that documented in your records or below. It can be done through creatinine level and estimated GFR through one of the formulas or 24-hour urine collection or whatever. So we have to prove that you have that magical number of 20 or below. And we notify you at regular intervals about your status on the list, active, inactive. And as I said, there is option to list in multiple centers. We counsel patients when they are listed for transplant to stay healthy, take your medications. If you're on dialysis, show up for your dialysis treatment, keep all your appointments, and inform us of any single change in your health status. Hospitalization, infection, blood transfusion, it's a big thing because it actually influences your panel of reactive antibodies. And make sure that the transplant center can reach you at all times if a kidney becomes available to you. You can actually have different phone numbers, different contact people who can find you if we call you in the middle of the night. Now, if you have a living donor, we evaluate the donor. We do an exhaustive workup of the donor. First of all, you must be ABO compatible with your donor. We get frequently asked about the factor RH, positive, negative. It's not important in living, in solid organ transplantation. It's important we respect it only on blood transfusions. Then we do tissue typing to match the donor and the recipient. We do something called cross match. We combine blood from the recipients with cells from the donor, and we look if there is any reactivity there, if the immune system has developed antibodies that can attack the kidney. And if an incompatible living donor is available and incompatible with you, the door is not really shut because there is an option for what we call the paired kidney exchange. We have been doing that actually with great success here at Mayo. We collaborate nationally and actually internally and with the other 2 sites in Florida and Arizona where we do something called paired exchange. If you and your donor do not have, you're not compatible, we actually find you another pair that have the same problem and simply we exchange kidneys as shown here, you know, colloquially called swapping kidneys. I don't like the word swapping, but it's actually an exchange of kidneys among the 2 pairs. Transplant surgery, Dr. Dean will go over that. The kidney is transplanted typically in the pelvis, hooked up to the lower extremity vessels, the iliac, we call them the iliac artery and vein. And it's a frequent question, what do we do with the original kidneys, the polycystic kidneys? Typically, we keep them there unless they're problematic. If there is any problem with chronic pain, if they're symptomatic, they have a lot of stones or infected, or there's no room, if they're extremely large and there is no room for kidney transplant to be implanted in the pelvis. The timing of that can be at the time of transplant. Sometimes we do it after, depending, or we do it before. We let the patient heal and then we do the transplant later on. So there are some downside of transplantation. Yes, it's the best option, but as I said, it's not a cure. There are risks related to the surgery itself, the use of anti-rejection medication, we counsel patients when we see them for the evaluation that there is slightly higher risk of having malignancy. This is why we're so particular when we do the evaluation in terms of flipping every stone to make sure they're healthy, and we get all the records about their health maintenance exam. Most cancers are a little bit higher in terms of compared to the average population after transplantation, can range between 2 to 3-fold. This is why we ask you after transplant to have a primary care provider and see your doctors. Skin cancer can be a problem because it's about 30-fold increase of risk post-transplantation. So you're expected to see a dermatologist on regular basis after transplantation. Those medication needs to be taken lifelong, so you cannot stop them. Otherwise, the kidney would reject, and you go back to dialysis, unfortunately. And early on, it can be a little bit cumbersome because you have to see the transplant specialist, and some do labs sometimes on weekly basis. You may need a kidney transplant biopsy. This early on, the first year is a busy year after transplantation. Thereafter, things would be better, and you don't need to do that many testing. So key points: kidney transplantation is a form of therapy. It's not the definitive cure, but it's the best therapy when you compare it to dialysis. Always we have the preference for preemptive living donor kidney transplant. You don't have to wait a long time. The good news in PKD patients, until we find a cure for polycystic kidneys, they have usually the best results after transplant because they don't have comorbidities related to PKD. Typically, just the kidneys failed from enlarged cysts. We do specific screening testing for PKD patients. We look for brain aneurysm. We look at the kidney sizes, liver cysts as well, if they're there, and may cause problem. But typically, in 99% of the cases, liver cysts are not that problem for transplant. And there are some risk related to surgery itself, the chronic use of anti-rejection medication, and those medication needs to be used lifelong. Thank you so much for your attention. Any questions?
Yes, actually, we have quite a few questions. Thank you so much for your presentation. The first question I have is, how successful are ABO incompatible transplants?
Yeah, that's a good question, actually. It's quite successful, actually. It's, similar to compatible transplant, but we have to be careful, when we accept incompatible pairs in terms of screening the titers of the call it the isoclitinin, the anti-antigen typically has to be low. And we condition patients with plasmapheresis sometimes and something called immunoglobulin, intravenous immunoglobulin. And most of the literature comes from Japan. Actually, we do it here at Mayo as well with great success. Typically, those kidneys live as long as compatible transplants. The first year may be a little bit cumbersome in terms of doing a lot of testing, more biopsies perhaps, but they're actually very successful in the right person and when we actually pick the right pair.
Okay, perfect. Thank you. So we have several questions about PRA. Can you tell us what that is? And also, if you have high PRA, would you recommend desensitization? Sorry.
PRA stands for Panel of Reactive Antibodies. I actually explain it to people in layperson words. For example, if you get a vaccination, your immune system reacts to that, or an infection actually, and produce antibodies. We call them immunoglobulin, okay? If someone had the previous exposure to blood, or a woman who had pregnancies, or previous kidney transplant, the body gets actually, the immune system got exposed to those foreign bodies. So they start to produce anti-human tissue antibodies. Blood transfusion is a big one. Actually, the red cells do not have those antigens, but there are fragments of white cells, fragments of platelets that actually express this HLA. And so the potential recipient actually produce antibodies, and it's actually very strong lifelong immunity to human tissue. And there are two different types of antibodies, class 1 and class 2. And based on the presence of those, patient can have a panel of reactive antibody from 0% to 100%. Unfortunately, 100% means that 100% of all deceased donors that are offered in this country, that patient has antibodies against and cannot get that transplant. We used to do a lot of active desensitization. Nowadays, we are shying off that because we have the option of paired exchange, where we actually pick the right donor for the right recipient. Because conditioning with desensitization can be actually, first of all, very costly. The IVIG infusion can be up to $30,000, $40,000 for each infusion, so it's so expensive. It's not guaranteed that it will be successful. Plus, it has also its own side effects on the patient. So nowadays, we're not doing as much desensitization as we used to do. We try actually, even if you have a patient with a PRA of 100% or 99%, and they have a living donor that's incompatible with them because of the presence of those antibodies, we can still get them a donor through the paired exchange program, whether internally or nationally, and that has been actually very successful. Now, the good news in a way, people who are very highly sensitized, back in December of 2014, the allocation of organs in this country actually changed and gave actually priority to people who have 100% PRA. So it gives them actually national priority on the waiting list. And people who have 98 and 99% give them more regional priority for deceased donor offers. But still, some people who have a lot of antibodies may wait long time to get transplant. So it can be a good thing, but can be also a curse because this can be a problem. Now, what we tell patients when we see them during evaluation, avoid blood transfusion at any cost, because you as a chronic kidney disease patient or end-stage kidney patient, you can get so anemic to a point that the nephrologist or your treating doctor would say, the best way to do it is to give you a blood transfusion. We tell people it's a no, unless it's a life-saving procedure. So if I would give you a main take-home message today, it's just avoiding blood transfusions. And if the blood transfusion is needed to save someone's life, actually that patient should be their own advocate by calling the transplant center if they're listed and telling them, my doctor is giving me a blood transfusion. What can I do? And it's needed because my hemoglobin is really, really low, and they said I have to have it. Then we put patients actually for a period of time, typically a month, on some anti-rejection medication to avoid sensitization. So this is a good question, and that's actually a frequent problem that we encounter. This is why we tell patients, we educate them when they come here to call us if they have any question regarding blood transfusion, which is a big thing. I hope this answers the question.
Yes, thank you. I believe it does. I know we're getting really close, but I wanted to ask another question. And we do have several questions about living donations. I'm going to save those for the other session. For BMI, do centers take into account the weight of the PKD kidneys and liver, which can be quite heavy?
Yeah. We take in consideration this. I mean, if they're really large organs and account for a significant percentage of the patient weight, we may actually take that in consideration in terms of the BMI. We do that. We also some people are on dialysis. We also try to get really their dry weight, because sometimes they're on the limit of the required BMI. For example, if someone has a BMI of 40, but our cutoff is, let's say, 38. Sometimes, accounting for certain things, we make exceptions as well, where the fat is, if it's more like all proportionate and distributed proportionate. So that's a little bit different. We take in consideration case by case when the surgeon sees the patient, and we talk about them in selection committee. We advocate for that, as but we always tell patients they should lose weight. But that's a good question, actually, because it's case by case. Any other questions?
Actually, we have quite a few more questions, so we may have to get answers to some of these after, because we are a little bit over. Let me ask you one more question. What is the frequency of PKD kidneys being removed? So nephrectomies.
That's probably Dr. Dean would answer this. I don't think it's high. Typically, just I don't have any data, but I would say less than 10%. A lot of times we keep those kidneys as well, because first of all, they produce epogen, so patients would actually benefit from that, so they don't get anemic. The cyst can still produce epogen. Second, if someone has some residual function as well in those kidneys, the kidney is still making urine. If they're not bothering them in terms of how large they are, or have a lot of pain in them and such. So I think it's a minority of patients whom we remove kidneys. And we have actually a center of excellence here, where we have patients coming from all over the country, to meet with our surgeons, because they're very equipped in actually doing the nephrectomy, or removal of the kidneys during the transplant surgery. I don't think it's just on top of my head. I don't have data to back it up, but I would say less than 10% that we remove the kidneys prior to transplant or at the time of transplant.
Okay, thank you very much.